Bronchial asthma. In bronchial asthma, there is impairment of airflow due to contraction of bronchial smooth muscle, swelling of bronchial mucosa, mucosal edema, and increased bronchial mucus secretion. There is inflammation and hyperresponsiveness of airways. The airway obstruction in bronchial asthma is mainly due to release of mediators. They are histamine, 5-HT, PG, prostaglandin, leukotrienes, proteases, PF, etc. These cause inflammation and hyperresponsiveness of airways. This finally lead to constriction of bronchioles. Because of constriction, the airflow will be impaired. For example, this is the size of normal bronchus. After constriction, it will become narrow. Because of this, there is airflow impairment. There are several factors that may precipitate attacks of asthma in susceptible individuals. They include allergy, infection, psychological factors. The airway obstruction in asthma is due to release of mediators from sensitized mast cells. Mast cells are macrophages which release inflammatory mediators. Bronchial asthma can be episodic or chronic. There are 3 types of bronchial asthma. They are acute asthma, chronic asthma, acute severe asthma, or status asthmaticus. Acute asthma is characterized by episodes of dyspnea associated with expiratory wheezing. Chronic asthma is characterized by continuous wheeze and breathlessness on exertion. Cough and mucoid sputum with recurrent respiratory infection are common. And acute severe asthma is an attack of asthma when it is prolonged and there is severe intractable wheezing. This is most dangerous than acute and chronic asthma. It is also known as status asthmaticus. Treatment of bronchial asthma. We use certain drugs for the treatment of bronchial asthma. They are bronchodilators, leukotriene antagonists, mast cell stabilizers, corticosteroids, anti-IgE antibodies. Bronchodilators. They help in dilation of constricted bronchioles. They decrease bronchospasm. They are of 3 types: beta-2 sympathomimetics, methylxanthines, anticholinergics. Salbutamol and terbutaline are beta-2 sympathomimetics. Theophylline and aminophylline are methylxanthines. Ipratropium bromide and thiotropium bromide are anticholinergics. Leukotriene antagonists. They are montelukast and zafirlukast. Mast cell stabilizers. They are sodium chromoglycate and ketotifen. Corticosteroids. They are systemic and inhalational. Hydrocortisone and prednisolone are systemic corticosteroids. Beclomethasone and fluticasone, flunisolide, circlsolide are inhalational corticosteroids. Omalizumab is anti-IgE antibody. There is a mnemonic for remembering drugs for bronchial asthma, that is ABCML. A stands for anti-IgE antibody, B stands for bronchodilators, C stands for corticosteroids, M stands for mast cell stabilizers, L stands for leukotriene antagonists. It can be remembered as ABCML or ABCLM. Bronchodilators. Sympathomimetics. Mechanism of action of sympathomimetics. They act on bronchial smooth muscle and mast cells. They act by stimulating beta 2 receptors present in bronchial smooth muscle and mast cells. By stimulating beta 2 receptors, there is increase in CAMP, which causes bronchodilation, inhibit the release of histamine, SRSA from mast cells, and they also promote mucociliary clearance. There are two types of sympathomimetics. They are adrenaline and selective beta 2 adrenergic agonists. Adrenaline. It is non-selective sympathomimetic. It produces bronchodilation by acting through beta 2 adrenergic receptors. It is useful in acute attack of asthma. Its use has declined because of its dangerous cardiac side effects. Selective beta 2 adrenergic agonist is important because they are used as first-line drugs for bronchial asthma. However, it has side effects such as hypokalemia, tremor, tachycardia, palpitation, and rarely cardiac arrhythmias. Selective beta 2 agonists can be taken by inhalational route. Methylxanthines. Methylxanthines inhibit phosphodiesterase, which increase CAMP and CGMP levels, which causes bronchodilation, inhibit the release of histamine SRSA from mast cells, improve mucociliary clearance in respiratory passages. Methylxanthines are competitive antagonists at adenosine receptors, which also results in bronchodilation. This is not seen in mechanism of action. It's an additional effect. Adverse effects of methylxanthines. They have a narrow safety of margin. Methylxanthines effects on heart are tachycardia, palpitation, hypotension. Sometimes sudden death can occur due to cardiac arrhythmias. Their effects on kidney is diuresis. Methylxanthines effects on CNS is restlessness, insomnia, headache, tremors, and convulsions. Methylxanthines effect on GI tract is a GI irritant. It causes nausea, vomiting, gastritis, and it also aggravates peptic ulcer. So what are the uses of methylxanthines? It can be used for bronchial asthma and COPD, that is chronic obstructive pulmonary disease, and can also be used in apnea in premature infants. Theophylline is used as an additional drug in moderate or severe persistent bronchial asthma. Aminophylline or caffeine is used to reduce duration of apnea in premature infants. Caffeine is much safer than aminophylline. Methylxanthines pharmacokinetics. Methylxanthines are well distributed all over the body. They cross placental barrier, blood-brain barrier, and are well absorbed after oral and parenteral administration. Food delays the rate of absorption of theophylline. Drug interactions. When sympathomimetics are given along with methylxanthines, they cause bronchodilation and cardiac stimulation. Methylxanthines will increase the effects of sympathomimetics. Bronchodilation is a beneficial effect, but cardiac stimulation is not required. When methylxanthines are given with phenytoin, rifampicin, phenobarbital, we all know that phenytoin, rifampicin and phenobarbital are enzyme inducers. They accelerate the metabolism of theophylline and decrease its effects. This leads to failure of theophylline. When metabolism of theophylline increased, it sustains really very less time in our body and it metabolizes quickly and it excretes quickly. So administration of theophylline along with enzyme inducers is of no use. When cimetidine, ciprofloxacin, erythromycin are given along with theophylline, we all know that cimetidine, ciprofloxacin, erythromycin are enzyme inhibitors. Hence, they potentiate the effects of theophylline by interfering with its metabolism. So, you may wonder, this can be a synergistic effect, but no, it causes theophylline toxicity. It causes accumulation of theophylline in our body by potentiating the effects of theophylline, by interfering with its metabolism. Anticholinergics. Anticholinergics are atropine substitutes. They inhibit acetylcholine effects and cause bronchodilation. They have a slow onset of action and are less effective than sympathomimetic drugs in bronchial asthma. These anticholinergics are the preferred bronchodilators in COPD and can also be used in bronchial asthma. Tiotropium is preferred over ipratropium. When ipratropium is given with beta-2-adrenergic agonist, it produces greater and more prolonged bronchodilation, hence used in acute severe asthma. Leukotriene receptor antagonists. Leukotriene receptor antagonists inhibit cystinyl LT1 receptors in bronchial asthma. Causes bronchodilation, suppress bronchial inflammation, decrease hyperreactivity. They are well absorbed after oral administration. They are used for prophylactic treatment of mild asthma and moderate persistent asthma. The adverse effects of leukotriene receptor antagonists are headache, skin rashes, rarely eosinophilia. Xilotine inhibit 5-lipooxygenase and is administered orally. It causes hepatotoxicity, which xilotine is a leukotriene receptor antagonist. Mast cell stabilizers. Mast cell stabilizers inhibit the release of various mediators like histamine, leukotriene, prostaglandins, PAF, etc. by stabilizing mast cell membrane. So, these mediators are formed inside the mast cell. By stabilizing mast cell membrane, mast cell stabilizers will prevent release of histamine, leukotriene, prostaglandin, PAF, etc. They decrease bronchial hyperreactivity, but the antigen-antibody reaction is not affected. Onset of action is slow. Sodium chromoglycate is not effective orally. as it is poorly absorbed from the gut. In bronchial asthma, sodium bromoglycate is given by inhalation. Uses of mast cell stabilizers. They are used in allergic asthma as a prophylactic to prevent bronchospasm induced by allergens and irritants, and also used in allergic conjunctivitis, allergic rhinitis, allergic dermatitis, etc. by topical route as prophylactic agent. The adverse effects of using mast cell stabilizers. They cause symptoms of local irritation, cough, bronchospasm, headache, nasal congestion, etc. Ketotifen is a mast cell stabilizer which has additional H1 blocking effect. H1 means histamine 1 receptor. Ketotifen has histamine blocking effect. Glucocorticoids. Glucocorticoids are steroids which promote synthesis of lipocortin, which inhibits phospholipase A2 and prevent the formation of various mediators such as prostaglandins, stromaxin A2, SRSA. Glucocorticoids have anti-allergic, anti-inflammatory and immunosuppressant effects. They suppress inflammatory response to antigen-antibody reaction and decrease mucosal edema, decrease bronchial hyperreactivity. Drug interactions. When glucocorticoids are given with beta-2 adrenergic agonists, they potentiate the effects of beta-2 adrenergic agonists. They also prevent development of tolerance to beta-2 adrenergic agonists. Long-acting beta agonists when given with steroids. Example, fluticasone and salmeterol, budesonide and formoterol. They have synergistic action used in bronchial asthma and chronic obstructive pulmonary disease. Uses of glucocorticoids. Systemic glucocorticoids are used in acute severe asthma, chronic severe asthma. Adverse effects of using systemic glucocorticoids for long duration are gastric irritation, sodium and water retention, hypertension, muscle weakness, osteoporosis, HPA axis suppression. HPA axis suppression implies hypothalamus pituitary axis suppression. Since the hormones are released from hypothalamus pituitary glands. Anti-IgE monoclonal antibody. Omalizumab is an example of anti-IgE and monoclonal antibody. It inhibits binding of IgE to mast cell. It prevents mast cell degranulation. It has no effect on IgE already bound to mast cells. When IgE binds to mast cell, before binding itself, anti-IgE monoclonal antibodies will act. It cannot have any effect when IgE is already bound to mast cells. It is administered parenterally. Uses of anti-IgE monoclonal antibody. It is used in moderate to severe asthma and allergic disorders such as nasal allergy and food allergy. It is approved for use in patients older than 12 years. Adverse effects of anti-IgE monoclonal antibody: redness, stinging, itching and induration. Treatment of acute severe asthma. Acute severe asthma or status asthmaticus treatment includes 8 steps. The first step is, first we have to give humidified oxygen inhalation to the patient. then nebulized beta 2 adrenergic agonist along with anticholinergic. We earlier saw that it's a synergistic effect. Salbutamol 5 mg or terbutaline 10 mg is given along with ipratropium bromide 0.5 mg. Systemic glucocorticoids. Intravenous hydrocortisone 200 mg IV stat is followed by IV hydrocortisone or oral prednisolone depending on the patient's condition, and then injection salbutamol is given. Intravenous fluids are given to correct dehydration. Potassium supplements to correct hypokalemia. We already seen that hypokalemia is caused by repeated doses of salbutamol, which I already highlighted before in adverse effects. And the seventh step is giving sodium bicarbonate to treat acidosis. And the eighth step involves giving antibiotics to treat infection. Now let us see inhalational devices. They are pressurized meter dose inhaler, dry powder inhaler, and nebulizer. Now there is an interesting question. Let's say it as quiz. I explained everything, and the question is, out of these drugs, how many drugs are available as inhaler in inhalation form? And the answer is beta adrenergic agonists are available in inhalation form, anticholinergics are available in inhalation form, mast cell stabilizers are available in inhalation form, and glucocorticoids are available in inhalation form. Now let us see some of the drugs we should avoid in patients with bronchial asthma. They are NSAIDs like aspirin, ibuprofen, and diclofenac. Paracetamol can be used, and beta blockers and cholinergic agents. These are the drugs that should be avoided in patients with bronchial asthma. I hope you understand the topic, and thank you.